So good evening, everybody. Good afternoon. Thank you very much for joining us for this panel discussion about life and business in the time of COVID-19. My name is Ian Campbell. I'm the CEO of Mission Suite, and this is the first in a series of panel discussions that will be hosted by Brian Cook, founder and managing partner of the Insurance Loft, Justin Davis, managing director of Soaring Tech, and myself to address some of the myriad questions that we're all asking right now. While Brian, Justin, and I were discussing the current crisis, we decided that instead of trying to come up with our own conclusions based on what we're hearing in the media, it might be helpful to gather some people who actually know what they're talking about to answer some of the more specific questions that we all have and hopefully gain a little bit of clarity around some of the important topics at hand. Starting off this series, we decided to jump in with a focus on the health aspects. And we've been able to gather three incredibly qualified individuals in the world of health and healthcare who I'm honored to introduce in no particular order here. We've got Remy Brim, who is a scientist and healthcare expert focused on strategic policy and advocacy support for clients with FDA regulated products who are navigating the complex regulatory and political landscapes that are required to advance the discovery, development, and delivery of innovative products. We have Aaron Rickman, assistant professor of surgery at Boston Medical Center with a focus on trauma, acute care surgery, and surgical critical care. And Jennifer Mitkowski, physician's assistant with Parker Family Care, and is currently running for state representative for House District 43, and that's down in Highlands Ranch. So first of all, to all three of you, thank you so much for being here. Really do appreciate it. And I'd like to start just by just with the three of you kind of jumping in and telling us a little bit more about kind of your experience with what you've been doing and maybe your experience with either COVID-19, coronavirus, infectious diseases, and whatnot. So I guess we can kind of, Remy, we can jump off with you here.
Great. Thanks so much for having me, Ian. Can you hear me?
Mm-hmm. Yes.
Great. Technology was successful today. That's a big accomplishment. Thank you for having me. So I work in Washington, D.C., representing, as you said, primarily the folks that are working to develop tests, develop therapies, and helping them sort of navigate sort of the new regimes at FDA. There's a lot of regulatory flexibility happening right now, so making sure they're getting connected to the right people. In addition, trying to advocate within Congress, within the three different Corona packages that have passed in order to make sure that we have the types of policies in there to help small business, but also to help facilitate the development of those products and make sure we have the regulatory schemes necessary to advance those products under a public health emergency. So I'll stop there.
We'll just kind of go down the list. Aaron, you want to give us some background?
Sure. So I'm a trauma critical care surgeon. So that means I do, my normal job is taking care of people in Boston who have either surgical emergencies or who have had some sort of traumatic injury, car crashes, get shot, get stabbed, something like that. And then that's about half of my job. And then the other half is managing the surgical ICU at Boston Medical Center. So patients who need critical care, et cetera. My current job, since the COVID crisis has started, we have shut down a lot of the elective general surgery practice and have tried to minimize as much as we can the other things that we're taking care of, just so that we can have the appropriate staff to take care of these patients. And so now I'm primarily helping to manage the critical care unit itself and helping to work with the other ICU doctors as we expand our coverage there. So.
Excellent, excellent, thank you. And Jennifer, can you give us some background?
Yeah, so I'm a PA. I work in family practice in Colorado. So we see kind of everything from, 2-day-olds to 101, I think is my oldest patient now. So it's been interesting with COVID. We've kind of tried to go all telemedicine for as much as we can. Obviously, there's still patients we have to see in the office. And essentially what we're trying to do is keep patients out of the ERs and the hospitals unnecessarily, to limit as much exposure and try and keep from really taxing the ER and the hospital systems. So a lot of the specialists in the area have sort of shut down for right now or have gone completely telehealth, and we're trying to kind of handle all of those patients and triage that stuff as much as we can virtually, so we can keep patients healthy and keep them out of hospitals and ERs. We're trying to get tests to be able to screen people. We have not been successful in being able to do that yet. We have a lot of patients that ask. And I spend most of my day currently talking to patients about COVID and their symptoms, and if they have COVID and what they should do if they think they have COVID. And that's pretty much what I do for 9-10 hours a day now.
Awesome. Very cool. Well, thank you very much. I definitely appreciate it. And just a note to our attendees here. Now, this is going to be a Q&A, but and I'll be moderating some of these questions here. We have some prepared questions that we've given to our panelists in advance, but we're also going to encourage you all to ask questions as they come up. So there is, in the bottom of your Zoom screen, you'll see a Q&A button with a couple little chat boxes that you'll be able to click on and ask the questions. Brian and Justin are going to be moderating those questions, and then towards the end of this session here, we'll get those asked as well. So yeah. So anyway, so now kind of the first question that I have, and I'm kind of posing this to all three of you, is what is going on right now? I mean, this seems like it's a bad sci-fi movie, right? So I guess from a starting point here, can you, I mean, and again, I'd love to hear from all three of you, whoever wants to speak up first. Can you kind of give us give us a rundown of what's happening?
Yeah, I mean, a bad sci-fi movie would be nice. It would be nice to wake up and realize this is a bad sci-fi movie we're in, right? It's uncharted territories, really. I mean, we've never really seen a pandemic outside of, 1918 and Black Plagues and things of that nature. In our living lifetimes, we've never really seen a pandemic to this of this extent and this magnitude, where we've had to, what is it? I saw the stat today, I think 95% of the country is on stay-at-home orders. And that's something I don't think anybody ever thought possible in the last, few months, so to speak, but it's our new reality for right now, and the foreseeable future. But hopefully one day we'll look back on it and say, okay, it's over now, and we can all move on.
I guess I would say from a inpatient sort of critical care standpoint, we're trying to manage and scale up as much as we can for the coming wave of patients that we're going to see. I think the expectation that even with good social distancing and the shelter-in-place orders that we have established, that the reproduction rate of this virus, the infection, the degree of infection that we're going to see means that a significant portion of the population in the U.S. is going to get it, and that we just need that to happen slow enough that we can keep our healthcare resources available to take care of these patients, and that we have the healthcare resources to take care of the other things that are going on. So even as this is happening, as more and more people get COVID, that doesn't change the rate of the other things like heart attacks, appendicitis, those other things that we would have to take care of usually. And so what we're trying to do as best we can is slow down the infection rate so that we can keep delivering good care to all the patients who come in. We are still working on treatments and therapies for this. At the moment, the best therapies that we have are mostly supportive. There's lots of ongoing studies on medications. We can talk about those certainly later, but we don't have good data for a lot of things yet. So it's mostly trying to mitigate risk as best we can right now.
Yeah, from the political perspective, we're in some really uncharted territory right now. On Friday, Congress just passed a $2 trillion, trillions, not billions, $1 trillion economic stimulus package, the largest economic stimulus package in history. That's larger than what we needed in sort of the financial crisis of 2008. I mean, this is Great Depression level economic impacts of the virus, and we're still sort of at the beginning stages of a lot of these stay-at-home orders. I know DC just went stay-at-home this week. We've been sheltering in place since last week, so we're sort of still on the front end of this. So in terms of economic impact, it's going to be huge. It's going to be long-lasting. We're already seeing the unemployment rates go up. It's going to change, the healthcare system, because people are going to lose healthcare. We're going to have, different, structures within the insurance system. And because this is such an unprecedented situation, and my physician panelists can talk about this, CMS, which is the Center for Medicare and Medicaid Services, which has jurisdiction over Medicare, Medicaid, private health insurance in different ways, has been rolling out flexibilities like we've never seen before. Scope of practice limitations have been lifted. Reimbursement for telehealth, making sure that folks can get reimbursed for the work that they are doing over the phone. So there's just so much government flexibility right now. There's also a big issue of sort of who's on first here. There's a lot of different agencies that have to collaborate to make these things happen. FDA works on sort of approving new tests and new products. Centers for Disease Control is supposed to be sort of quarterbacking surveillance. NIH quarterbacks research. The Assistant Secretary for Preparedness and Response and FEMA are supposed to collaborate to get things out of the national stockpile to the hospitals that need them. So there's a lot of different hands on deck, and it's not always clear exactly who is in charge of what, and whether the person at the head of the agency is really the one in charge. This administration is a different type of administration than ones we've seen before. So a lot of power is concentrated in the White House right now, and different folks running point there. So from a political perspective, I think everyone is trying to have as much flexibility as go down to the states and the providers that are on the front lines. But, from the economic side, this is really unprecedented, and I don't think that this will be the last stimulus package you'll see out of Congress, which is currently out of town on recess until the end of April, but we're probably anticipating that looks like more like May.
Yeah. Okay. So, and I get, Remy, you bring up an interesting point about, kind of all the different players that are involved at at kind of a government level. Aaron, Jennifer, I'm kind of curious, do those types of things that are happening there, are you seeing an impact on things like that just in your day-to-day life and in your practices?
Yeah, I mean, with CMS lightening regulations and stuff, we're certainly seeing the impact on that. Telehealth, that was one of the first things that we were able to get implemented. And up until now, it's been a very difficult thing to get reimbursed, and reimbursement for it was pretty low. And essentially what we've been told by the insurance companies and CMS is do it. We're reimbursing like it's office visits. We're just going with the flow and doing what we have to do. So that's been a really useful thing in this kind of current environment, because from the standpoint of our small family practice, we would be in real trouble right now if we couldn't do telehealth, because we wouldn't have the capacity to stay open if it weren't for telehealth, and also keep the patients safe. Right? We don't want patients coming in or traveling out if they don't have to. Stay home and talk to us on the computer. So the changes that CMS has been able to put into place, and then also with licensing, they're speeding up how quickly our new grads can get licensed. They're sort of waiving some of that state to state stuff, so that places where people are really needed. I have a good PA friend that just went to New York to have New York City. Some of that stuff's being waived a little bit so that our scope of practice is larger, and we can help out in places where it's really needed right now.
And from an inpatient standpoint, I think we have in Boston at least, we've seen in anticipation of this, we saw a pretty rapid decrease in the amount of patients who are coming into the ER, and the sort of stuff that would end up getting moved to hospitals for management. The ability for the telehealth capabilities has helped clear beds in the hospital and to make sure that we are able to have room for these patients as they come in. So those adjustments have been helpful. I think we are a little bit behind the 8 ball in ramping up production of things. So the current issue that we are facing right now today is we're running low on some medications that we need for these patients. So sedation medications, pain meds, and some other more advanced things that we need to take care of the sickest patients, primarily because, as we have more patients on ventilators, we're burning through our stocks nationwide faster than we do typically. And so we're going to need to really scale up production. We've seen a big sort of coordinated effort to get things like ventilators, but I think as we get those things running, there are a number of other things that go into it that are smaller that we need on a continuous basis, and we are sort of reaching for those things and hoping that industry can kick up the pace on those things as well. And so those are the main needs that we have seen. It's just that we need everybody to stay away from each other and stay healthy as long as we can, so that we can have that little bit of time for our production lines to speed up.
Absolutely. We got an emphatic nod from Jennifer there too. So, I think we're all kind of at that point where we're realizing how important that is. Remy, from your perspective, Aaron mentioned that personal protective equipment and things like, medication and things like that are, and ventilators and whatnot. I mean, and we all know, we've all been hearing that we're short as a country, we're short on those things. And there's been a lot of talk about whether it's the president implementing the Defense Production Act, or just encourage the government encouraging companies to kind of abandon what they're doing right now and focus entirely on this. Is there any indication in DC that something is actually going to be passed down from the government to kind of help the folks on the front lines to alleviate some of that kind of stress?
I mean, I think that's the goal of a lot of the policies that were in sort of this, we call it affectionately Corona 3, Friday's big package. But there's a lot of policies that were in place, that were put in place a long time ago, primarily after 9/11. We have a national stockpile. I don't know if everyone knows that. It has, PPE, meds, ventilators, all those things. What we're seeing is that it's basically run out already. The stockpile is sort of not kept up. After H1N1, a lot of the PPE was not replenished. So, that was an oversight in the preparedness part of this. We have a stockpile, but the stockpile is only as good as what is in the stockpile. If folks are curious, the stockpile is not in one location. They're sort of in undisclosed locations around the country. There's mass warehouses that the government funds and long-term contracts with manufacturers to make sure we have, to ramp up for these sorts of things, so we aren't in these situations. So I think we're sort of learning. This is the first time we've had, there's sort of a first time for everything. And you hate to say it, but you can plan as much as you want, but until you get into sort of the thick of it, it's hard to, necessarily plan ahead. In terms of ventilators, there's been a lot of press, whether it's GE or Ford or Honeywell sort of changing over their production lines to make ventilators. They can do that now if they want to. It's obviously private industry can take that charge. There's been conversations about whether the government will actually mandate that. I think that's a possibility. I think at the end of the day, the mandate to those specific companies will end up being more of a political activity more than actually doing more. Those folks who are actually working to convert factories from making a car or an air conditioner into making a ventilator, that takes time. It's not that those folks are, really dragging their feet. It's that it takes time. We need to make sure if we have a ventilator, it works, and it's up to the standards that, medical professionals and healthcare professionals know how to use. So, there are those authorities. Personal protective equipment is actually considered a medical device. The class 1 low risk medical device, sort of like Band-Aids and other things you wouldn't necessarily think of as a medical device, but it is regulated by FDA, and FDA has taken a lot of liberties with loosening its restrictions on PPE. Things that wouldn't necessarily be considered PPE or be able to be sold as PPE, they have loosened those restrictions so that medical professionals are able to use PPE that might be used traditionally in a construction environment, or I know there's a lot of folks, just on the phone with my mom, she's sort of making masks, but, there's certain specifications that the FDA is actually saying they're okay with. So it's going to be a longer term, we sort of need to get through this stretch, but I think longer term, there's going to be a lot of conversations about what should the national stockpile look like, how should the national stockpile be managed in terms of supply chain, and do we need to have a bigger conversation about supply chain, because obviously a lot of this is happening in different regional parts of the country. The curves look different depending on where you are and sort of where you are within the peak in your own region. So whether there needs to be more control over how sort of private companies, whether it's tests or PPE or ventilators, how are those getting out and how are those being managed on sort of a countrywide basis?
Gotcha. So I guess some of the questions that were kind of submitted to us beforehand, before this, really a lot of it kind of revolves around the question of, are we overreacting, right? And is that how much and obviously, I mean, how much of this is how much has hysteria played into this versus how much experts have confirmed and said, yes, we need to be doing this? And then also, why are we responding so heavily to this with lockdown orders and shelter in place and things like that? Whereas, there are other illnesses, other diseases and whatnot that are killing more people per day than COVID-19 is, right? And so I guess I would love if, I'd love for the three of you to speak to that. Remy, I feel like you have a response there that is something, based on your reaction. I feel like you might have some input there.
I don't have a very good poker face, so I'm terrible at Zoom panels. I really sort of defer to some of the medical professionals. Obviously, they have been to med school. I have not, and would love to hear their perspectives. But, I do think that there is a level of, like you said, there are diseases that kill more people per day. But if you look at the trend charts, if you look at sort of deaths per day in certain regions, it has sort of climbed up the sort of rating system of deaths per day. And the other thing is that, folks that are focused on treating very, very sick patients can't focus on treating other sick patients from those other diseases. So from a healthcare burden perspective, it is something that we need to take into consideration. But I do think that there is, we're all learning. The governments are learning, state governments, local officials, everyone's sort of learning as we go here. So whether it's schools being closed or parks being closed, tennis courts being closed, I mean, there's a lot of things that, of course you want to have social distancing, you want to take precautions, but there's some things that when you put them, I am a scientist by training, don't actually make sense, right? If I play tennis, 20 feet away from someone, that's not necessarily, and I don't touch my face and I wash my hands, you do all the right things, but then you're also trusting people to be able to do all those right things and still have those, sort of have some of those privileges. So I do think there's sort of a balance there between, what are the freedoms that we want to have? What are the sort of expectations we have of individual people in society to act the way they should act versus sort of forcing people to do things that might be above and beyond, but then you're sort of catching the bottom net and making sure that those folks that might not take those same precautions are, being protected. But I really defer to the medical folks to answer that one.
And we should probably note that none of this should be taken as medical advice. If you have questions about this, ask your provider, right? I mean, don't think of a webinar as a medical tool, right? Just to kind of lay that out there too.
Yeah, so Aaron's kind of hit on this about allowing us more time to prepare, right? So that's the biggest concern with COVID-19 versus, say, other diseases like the traditional flu and things like that. When we talk epidemiology, we talk about what's called the rho naught, which is essentially how many people, like if you get infected, how many people you will infect. from being infected. And in flu, that number is about estimated to be like 1.3 to 1.5. So if you get sick, you're estimated to infect anywhere between 1.3 and 1.5 people. With COVID-19, we're seeing that number closer to 2.5. And that, I mean, it's just an exponential growth in the amount of people. The other concern is that no one has immunity to COVID-19. We don't have a vaccine like we do for flu. We don't have people who have had it before, and so are not going to get it. So everyone is susceptible to it. Whereas flu, as a healthcare provider, right, I get my flu vaccine every year. The first like 3 years of medicine, you're sick every day. And then you just sort of build up this immunity to things. So you worry a lot less like during flu season. But with this, no one's been exposed. So everybody is a potential harbinger of the virus and has the potential to be exposed. That goes along with that 14-day incubation period where we've got people, we don't really know what's happening in the potential of the 14 days from when they get infected to the potential when they're showing symptoms, right? And so part of this is slowing down how fast that curve is growing so that we have time to gather supplies and medicines and ventilators, and we don't overrun the healthcare system. That's our biggest fear. This is what happened in Italy when they started seeing 700 people die a day. The healthcare systems were overrun, and they basically had to choose who they could treat and who they were just going to send home and say, sorry, we don't have the ability to treat you because we're out of stuff, and good luck. That's a scary situation and a very real thing that can happen if we don't slow down this growth. So it's easy to say we're overreacting and there's hysteria, but part of that is also looking at this as being prepared versus like saying it's overreacting, right? What we're doing is looking at the data that we've seen come out of China and South Korea and the other countries who have experienced this already and saying this works, social distancing works, telling people to stay at home works. I had a kid not too long ago, a 3-year-old, and mom thought they were doing all the right things, but they went to the park. Well, guess where the kid got COVID from the park. She's like, that's the only place we've been. I said, I know, but that's all it takes. There can be one person at that park that's not staying home, that's going everywhere still, and has the virus, and then there you go. So that's where the real concern comes from.
Yeah, and I think the death per day rate for COVID at the moment is based on, we have the CDC numbers that were quoted on March 9th that you guys sent. That's for an infection at that a month ago with infecting somewhat less than 10,000 patients worldwide. We just crossed 1 million confirmed COVID-19 cases worldwide. And so that death rate per day, if the lethality of the virus stays about where it we think it will, which looks like somewhere around 3 to 4%, that number becomes a huge number once you infect 70% of the adult population worldwide. There are a number of things about the disease that we don't know. So as I said, lethality is somewhat mobile at the moment. We don't know, and it seems to vary depending on the populations that you're looking at. And the R0 value that was mentioned earlier, the number that we're looking at for the most part is around 2.2, but in some places it's up as high as 6. And so that, there's a lot of things that if you were trying to design a virus that could cross the globe and impact the human race universally and severely, it's hard to build something better than this particular virus. So Ebola is certainly frightening. Hemorrhagic fevers are terrifying diseases, but a respiratory virus that kills 5% of the people it infects is hard to beat as far as a global pathogen. And so and the other problem with that is that people who get sick with this stay sick for a long time. So even if you recover, that's still at the moment we're looking at roughly a month of being infirm with this if you get the more severe manifestations of the disease. And so that sort of length of illness as you infect millions of people means that we then can't take care of people who are presenting to the hospital with other issues. If we don't have beds to take care of those other things, that's the secondary impact of this. So if you, as you exhaust the resources taking care of this disease, the other diseases that are also, you know, more manageable but require resources become unmanageable.
Right. And Aaron, you know, Jennifer touched on in Italy where they had to kind of make decisions on who they send home and say, sorry, but best of luck, and you know, who they take care of. I mean, I'm not exactly sure how to ask this question, but I mean, that seems like I mean, I don't even know how to ask this, but how do you make that decision? How do you have that conversation as somebody who's, you know, as somebody who's dedicated their life to kind of doing this? I mean, it seems like that's like one of the less talked about impacts of this, is that, you know, at some point, people who have dedicated their lives to helping people have to say, sorry, I can't help you.
Yeah, so we are, at the moment, each hospital system is sort of working on how to make those decisions in their own particular way. So, you know, the way that the Italians did it was they started with an age requirement. So they, you know, they decided that you're older than 80, we're not gonna offer you a ventilator, we're not gonna offer you intubation. And then as they ran out of resources, that number marched down. I think we are trying to avoid that here, again, by, you know, flattening the curve, as we keep saying. There are some objective ways to do it, or things that we think of as objective, looking at, you know, scoring systems for assigning how ill a patient is to decide their likelihood of recovering from critical illness. And if we, you know, we could use those scoring systems to decide, you know, this person is unlikely to be salvageable, but those are very difficult decisions to make, and we are having now to come up with how we're going to make those decisions if we get pushed to a point where we don't have resources to take care of everybody who presents. And so at the moment, every group of healthcare providers is trying to come up with that, so that we have those decision-making tools ahead of time, so that it's not just falling on one person, and then we can look at, you know, this is the committee's decision that this is how we're going to assign these patients. And it is a difficult decision to make, and we're trying not to make those decisions in isolation as much as we can. And at the moment, we don't have to. We have enough beds, we have enough ventilators here, and so, you know, if things continue to move the way they are, then we may be okay, but that's what we're counting on.
Yeah. Somebody from the audience, Travis Clower from the audience, asked this, and it seems like a good time to bring this up. Does anyone know what happens if you catch it and recover? Can you catch it again? Does your body develop a resistance? Can anybody kind of speak to that a little bit? Do we have data on this?
So we don't know for sure. There are several hundred different varieties of coronaviruses that exist. We know that people form relatively robust antibodies to other coronaviruses. The question is the duration of how long you retain those antibodies once you create them. The mutation rate of the virus is also the question. So, you know, the seasonal flu mutates enough each year that, you know, you can get reinfected every year, but that your body hopefully doesn't respond to it with the same virulence each time. We don't know that well for this virus. We do know that convalescent serum, so patients who have recovered, they create an antibody or an immune response that is transmissible. So if you use their plasma and treat an ill patient with that plasma, that particularly ill patient seems to recover faster, and the severity of their illness goes down. And so that is a good sign that we are able to form antibodies or a coordinated immune response to this virus. But it will, only time will tell at the moment if it mutates fast enough that it can outpace our body's ability to create a durable immune response.
Jennifer, you spoke a little bit about seeing people with kids, and from someone with a family practice perspective, I'm sure you see this, or could potentially see this quite a bit. But now we're all working from home, or in small rooms above our garages or wherever we are, right? And kids are going kind of crazy. Kids are going just as stir crazy as we are, only they act out more than we do sometimes. So I guess my question for you is, from a family practice perspective, what can we do? I mean, letting kids play with other kids, letting kids, is there anything that we can do to get that kind of outdoor, that interaction with kids while all this is going on?
Yeah, it's tough, right? I have a 3-year-old and a 6-year-old, and yeah, we're at wit's end. But no, play dates are definitely off the table. Like I said before, you just never know what other people are doing, right? So say that part, and for me, right, I'm essential personnel, so I go to work every day and I'm still seeing some patients. So what if I was infected and didn't know? And then my kids have a friend over and now I've infected them and the whole family, right? So that's why social distancing works, right? And we don't do things like go to play dates and go to the park and that sort of thing. Here locally, we've actually closed all of our parks and things of that nature. They can go outside. Mine go out in the backyard a lot. We do a lot of bike rides around the neighborhood. We do a lot of FaceTiming with our friends, which can be good and bad because then they just want to go over there. But even with the 6-year-old, we've sort of had to sit down and have this conversation about this is what's going on. This is why you can't go back to school and see your friends and see your teacher. And look, we're lucky we live in a day and age where we're quarantined and have technology. I can't imagine this 20 years ago when we had no ability to do anything virtually. So they can at least Zoom call with their friends and do things like that so they can interact a little bit. And we're lucky the weather's starting to be nicer so they can go outside. Some today it's like ice raining and snowing outside. So today's been a little rough. But things like that. My 6-year-old doing virtual Taekwondo. So that's been a good outlet for her. But yeah, play dates, just like everything else, a bad idea right now. And the sooner we get everybody to stay at home, the sooner this thing flattens and we can get back to normal life, right?
Mm-hmm. So that actually brings up 2 questions that I have that for the 3 of you that I'd be interested to hear from both kind of practice and policy perspectives. So first of all, we hear about herd immunity, right? This concept of herd immunity, where if we surround one infected person with 1,000 people or whatever the number is, right? I mean, you can contain it, you can kind of control it and keep everything at bay. And then on top of that, at some point, we're all going to have to go back outside, right? I mean, we can't keep we can't keep this up forever. At some point, quarantine is going to have to end. Well, I guess not technically, but I mean, realistically, just if for no other reason than for our sanity, it's going to have to end. So what happens? And, is the fact that we've been sheltering in place for so long going to impact the herd immunity, the benefit that kind of herd immunity can come upon? Is it, what happens when we go back outside? How do we kind of navigate this moving forward?
That's part of the unknown, like Aaron was talking about. We don't know. The data we're seeing is promising for the fact that people develop strong antibodies to this. But the question is, how long do they last? Are those antibodies good for 6 months and then you can get infected again? Does it mutate and does it do something else? What they saw in Hong Kong was the second they thought they were okay and they lifted some of these policies and allowed people to have a little more going out and things like that, they saw a surge again. Then they sort of went back to how they were so they could squash that again. But I think this is where we play it really safe, right? And we say, okay, it's not just saying, okay, we flatten the curve now so we can all go outside and go back to our normal lives. We have to say we've done the job of flattening the curve, and now we need to wait until we're really sure that this is a time where we can go back outside and not see a huge, surge in those numbers again. It's going to be tough because everybody's anxious to just get back to normal life. We're going to have summer soon, right? And everybody wants to be out and traveling. I already have friends asking me, like, can I travel in July? No one knows really at this point, but the answer is probably not going to be recommended at this juncture, right? It's why we're just taking this step by step. The worst thing that happens, in my opinion, is we stay home too long and we just don't see this thing grow. Like ideally that's what happens, right? We overreacted, we stay home too long and nothing happens. And we were wrong, and maybe we could have gone out a week or two sooner, but it's better safe than sorry at this point. And that's what I think we should do, but we shall see where it goes.
Yeah, there is the frustrating thing about pandemics or outbreaks is there is no way to be right in your management. So if you manage it wrong, everybody gets sick, lots of people die, and you look like you failed. If you manage it well, it looks like you overreacted, nobody gets sick, and people think you made a whole bunch of decisions that were unnecessary. So there's not really any good way to win at this, if that's the way that people are looking at it. But as far as long-term management, there are a couple of companies that are working on vaccines. If we can develop an effective vaccine for this, then that's great. That's an excellent end game. It means that we have a way to at least for short term control it. We can control recrudescence of the virus if it pops back up in regions or mutates slightly, and we have some cross reactivity there. Then that gives us an opportunity to control it in a way that does not involve social distancing and involves more direct therapeutics. I think, there are obviously lots of studies ongoing looking at medications for treating the infection. I am, less confident that we will develop good therapeutics for antivirals. The viruses themselves are very difficult to control with medications. And so there are things that we can do for it, mostly as supportive care, but it's not going to be, I would be very surprised if we come up with some sort of pill that you can take that helps clear coronavirus. We're looking more at augmenting immune system things with vaccine probably. And then improving our ability to deal with a whole bunch of patients who have ARDS in the long run.
Remy, your thoughts, and then we'll open it up for Q&A.
I mean, I agree. There's really there's no way to win, and we've talked about this, for political nerds here. Sort of, what does this mean for the election in the fall? Is it good management? Is it bad management? Sort of what's happening. I think I agree with you won't win here, right? It's either an overreaction or it wasn't, and we'll never sort of know in retrospect. I think one of the things that we're focused on is, there's the management of the virus, there's the management of the burden on the healthcare system, there's also the management of the economy. We've seen go back to that, but, that will have lasting ripple effects that will go on much longer than the actual public health crisis. And figuring out, there is no really way to weigh, sort of public health versus the economy. It's not something, there's not like a calculation you can plug it in and figure out, the right measures. But I do think that, there will be, the longer this goes on, the more folks that, aren't getting paychecks, that are losing their jobs. And there's going to be a lot of sort of, there's going to be some tension and some unrest about, when we make those decisions. And I think that those political pressures are going to weigh on both the federal government, but also the state and locals that are, putting these orders in place. They're going to have to balance the pressures that they're getting from the different communities and make some of those decisions.
Mm-hmm. Excellent. All right. So it sounds like I'm hearing that the worst that can happen is we keep more people alive. And which is a good thing, I suppose, right? But to your point, there's certainly going to be some impact on that the longer that we stay inside. So, all right. So I'm going to bring Justin Davis on here. Justin, I'm going to unmute you and activate your camera, or ask you to activate your camera so that you can ask some questions from the audience here.
Hi guys, a lot of good questions here. So I'm going to start with a timeline for a new flu vaccine that may include COVID-19, or maybe at least just timeline for a vaccine for COVID-19 itself. If anybody has any thoughts on that, please jump in.
Yeah, 18 months is what the data is looking like. Dr. Fauci today said we think we're at least 18 months out. My guess is it'll look something like it'll not be part of the flu vaccine, but be something we get, maybe in conjunction with the flu vaccine during that season, depending on if we can figure out if COVID has a season or doesn't have a season, and we don't really know that data yet. Yeah, we're at least 18 months.
I'm seeing a lot of nodding heads. Okay. And then part two of that is, what do you guys expect to see then in the next 3 to 6 months and even a year from now, especially with that in consideration? And this is from Jeff Mason. Thank you. Thank you, Jeff.
Also, if people are able to, if we develop pockets of herd immunity, as if there is durable autoimmunity that we can develop, then that's great. But if not, then we're going to see what happened in Hong Kong. It may just be that Hong Kong released or lifted their sanctions too early, while there was still asymptomatic carriers in the population who hadn't yet cleared it, and so as we get better data about the long-term impact of this on people and how long they shed and carry the virus and how long they can remain infectious, we'll be able to guide that better. But it unfortunately just takes time, and we have to run these sort of, they're not really experiments, but basically they end up being functional experiments in these little in pockets to see what happens.
Yeah, I think everyone sort of wants to know that, the answer to that question, whether it's happening after the end of a month or 6 months. I think we are just in a really unprecedented time, and there's a lot of unanswered questions, and I think anyone that tells you that they know is lying to you. There's going to be, we're going to have to see how the stimulus package works to see if we have to, does more money need to come in the economy? Center for Medicare and Medicaid Services is looking at continued flexibility for healthcare providers. We're going to continue to try to figure out capacity for things like, essential medical devices, drugs, looking at how fast some of that drug development takes. A vaccine, I totally agree. That's a long 18-month type of process. Some of these therapies that aren't actually treating the virus but are more supportive, and we found people are looking at sort of different indications for products that are already approved that can happen faster. Sort of new targeted therapies that will actually address the virus are going to take longer because yes, everyone wants a therapy, but we also don't want snake oil out there either. We have to make sure that these things actually work.
Fair enough. Jennifer, anything to add to that?
Yeah, you're right. This is what happened when we started touting the hydroxychloroquine. And now I have autoimmune patients that can't get a hold of their medicine that they need for their autoimmune disease because people started requesting prescriptions for it like crazy because they thought it was the cure-all. But that stuff takes longer. Viruses are very difficult to treat. They're just a whole different kind of beast than throwing an antibiotic at something. Yeah, I think immunizations are best bet, right? But we're at least 18 months.
To piggyback on that timeline question, we do actually have another question from Travis Clower about the virus's response to heat, and is there any evidence to suggest that summer temperatures will help slow down the current situation? And then is it possible that we might see another surge in the fall? What are you guys' thoughts on that?
Yeah, still all unknown. I mean, heat in general does kill viruses, and they have done some research proving that high heat temperatures can kill the COVID, but we are seeing it in pockets like in Australia and things that are in their summer, which, is not great sounding really. So that it's a wait and see again, like we just don't know. We do know, like I said, that heat kills viruses and generally is why you're less sick in summer. We have more humidity, so it tends to carry less in the air, respiratory droplets and things of that nature. But we just don't know. And resurgence in the fall is the same. It depends on, how long people have antibodies for it and how strong those antibodies are and that sort of thing.
I think a lot of the early things that have indicated that warmer climates or more equatorial climates have lower impact were misinterpreting the epidemiologic data that was showing up. The reason that Central Africa has not seen this huge influx is mostly just because that the pathway of the virus, piggybacking on humans on airplanes, did not follow that pathway. So, there is a direct trade line from Wuhan to northern Italy, with a lot of people transiting back and forth between those two regions, which is why Italy got hit first. And so it's important not to interpret human behavior patterns as telling you something about the virus.
That makes sense. Remy, do you have anything to add to that?
I don't.
Okay. So we have a couple of other questions here. So there's been mixed advice, conflicting advice about wearing a face mask. And this is kind of something that I may kind of piggyback my own question onto this. But do you advise when you are going out in public, the average person going out in public, do you advise them to wear a face mask? Should they be covering their face? Is there anything that the average person can do to help in that situation? But then the second part of that question, this is my question, is if we do have extra personal protective equipment, should we donate it, and how do we donate it? Is there a clear pathway to do that? So I'll leave that open just to whoever wants to jump on it first.
On the PPE question, different states have set up sort of ways for folks to donate. I'll use Massachusetts as a good example. The state has set up a portal. There's a huge biotech industry, and obviously from work in labs, they have PPE on hand, and a lot of the biotech companies there are funneling their PPE sort of into the state stockpile. Same thing I've seen in Washington State, Ohio. So different states around the country are sort of looking to industries in their states that might have PPE for non-medical uses to be able to funnel that in. On the mask issue, there has been back and forth. I mean, I'll defer to the medical professionals here, but the masks do well at keeping your sort of droplets in your face, right? It's not necessarily going to help if someone sneezes on you. It's not necessarily going to, it can still sort of get in the side if you're not wearing sort of a perfect mask or using sort of one of your improvised or my mom's sewn masks. But it can help sort of if you're asymptomatic and you don't know you have corona, sort of keep it to yourself. I think there's another question of, we have a shortage of PPE. We've heard from the hospitals that they don't have enough masks, or medical professionals are being asked to wear the same mask for 5 days. Where do those masks need to go? So I think that there is, again, sort of a balance there of sort of what's the benefit to the general population who should be at home versus what is the benefit to making sure that we're routing that equipment to the folks who really need it.
Yeah, I think the other thing there is the mask can be both a benefit and a hindrance. So if you are wearing a mask and you are good at wearing a mask, so the mask works to protect you if you don't then continuously adjust the mask and touch your face and readjust the mask, and then and the same thing is true of like wearing gloves when you go to the grocery store. So the gloves are not protecting you. The virus is not making it through the gloves into your hand, or when you touch something, let's say a doorknob has coronavirus on it, the virus is not making it into you through your fingertips. It's making it using your fingers as a vehicle to get to your face. So if you put gloves on and touch a doorknob and then touch your face, the gloves have done nothing for you. The key is minimizing contact and making sure that every time you're thinking like, when's the last time I washed my hands, wash your hands.
That's the
Fair enough.
it's one of the things you learn very quickly in surgery, as Aaron can attest to. There's nothing like getting yelled at by a surgical scrub nurse, and you will realize how often you touch your face once you put gloves and masks on, because it and I see it at the grocery store, with people out with masks and gloves, and they're taking it off, and they're at the water fountain, and the gloves have touched everything and then touched their face, and it's just not doing you any good.
Gotcha.
Pretend it's like a
Well, I
scuba
think
mask, where if you took it off, you drown.
Fair enough. Fair enough. Well, I think we have time for one more question here. So I'm going to ask about what we can, and this is from Tricia. She is asking about how we can do, maybe we can do a better job about flattening the curve. I'll just paraphrase here, but other countries, Asian countries, appear to have done a better job at slowing or containing the spread of this virus. Obviously there's some cultural differences in the United States that may make that a little bit more difficult, but I guess bottom line, do we, would you recommend a more strict quarantine or shelter at home policy?
It's hard, right? And culturally, that is different. We have our freedoms and like our freedoms, and you don't want to tell people you can't leave your house. But what we're seeing is that people aren't listening. We're on a stay-at-home order in Colorado, and have been for a week today. But still, when I drive to work, I cannot tell you the number of people I see at the park. The state park this weekend was maxed out capacity-wise by 9:30 in the morning because they had so many people there. So, you look at saying, well, it's harsh to say you can't go anywhere, but, you try and do the least stringent thing, which is say, stay at home, only go out if you're essential, only go to the grocery store if it's essential, only go every 2 weeks. I know people that are going every single day, and then are out, playing basketball with their buddies. So it's difficult because it's hard to put more restrictions on, but that is the only way that we flatten the curve, because we have no other way to take care of this virus right now except to try and slow it down and prevent people from contaminating other people.
Yeah, and there's some, it's not just necessarily the cultural differences, but there are sort of limitations on, federal authorities. There's limitations on state authorities, and that's baked into the legal framework of our country. I think a lot of, folks are, I live in Washington, D.C., our National Guard is out. The cherry blossoms, you see the pretty pictures of every year. They're being defended by guys with AR-15s. So you can't cross the threshold because people were not social distancing the weekend of cherry blossoms. Everyone wanted to go down there and see them. And so, there's sort of a limit there. And I think when folks get very nervous when they see guys with very large guns patrolling our country, that's not something that we're used to in this country. And it's not part of daily life here. And it's not part of our legal frameworks to have these sort of, really strict orders in place. So I think, in addition to the cultural, there are those sort of legal barriers to doing things like that. And we're sort of trusting that people will do what they're supposed to do here. And that's hard because people don't always do what they're supposed to do.
All right. Well, I don't know if Aaron, if you have anything, just a yes. Okay. Fair enough.
Awesome.
All right. Well, with that, I will hand it back to Ian.
Excellent. Thanks, Justin. I appreciate it. And to the three of you, I really do want to say thank you very much. It's been great having you here, Jennifer, Aaron, Remy. It's been insightful, and I think it's been really helpful to answer some questions. There may be some more questions here in the Q&A section that we need to get to, and we'll see what we can do to kind of parse those out, maybe gather some insights and push it out in a follow-up email. This webinar will be available for viewing moving forward as well. So it is something that's going to be online, and we'll be pushing it out through LinkedIn and email and whatnot as well. So thank you, all three of you, so very much for being here. I really do appreciate it. And like you mentioned, I had no idea how much I touched my face until I had to watch a video of myself listening to other people talking about how bad it is to touch your face. So, but yes, all three of you, thank you very much. I really do appreciate it. It's been a great time having you here, and we'll talk to you very soon. We'll hopefully get a chance to see you all once this is all over.
Thank you.
Thank you.
Thank you. And for everybody else that's on the webinar, keep in touch. We'll be doing another panel discussion focused around finance, money, business, and whatnot here in the next week. Probably it's looking like early next week. So keep an eye out for more emails. Keep an eye out on LinkedIn, and we will look forward to talking to you all soon. All right, everybody. Cheers. Thanks again.